Good afternoon, everyone. I would like to welcome you all to the 18-month progress report on my PhD thesis, which focuses on assessing the efficacy and safety of proton pump inhibitors. About myself, my name is Elena. I'm a PhD student here in the CTM and at Grigore Tepopa University of Medicine and Pharmacy, and a resident doctor training in gastroenterology. And under the supervision of Balint Eros and Vasile Liviu-Drug, we plan to improve the clinical management of patients with gastroesophageal reflux disease by assessing the efficacy and safety of acid-suppressive drugs. For this, we have two very specific goals: systematic reviews and meta-analyses. Allow me to talk in a bit more detail about our first project, which is focused on assessing the therapeutic effects of acid-suppressive drugs in patients with non-specific chronic cough by means of systematic review and meta-analysis. As we all know, the Montreal Consensus recognizes chronic cough as a potential form of extradigestive gastroesophageal reflux disease. It is a very important topic because it has a high global prevalence, estimated to be around 9.6%, and is a significant cause for quality of life impairment. Over the years, acid-suppressive drugs have been proposed as a potential therapeutic options for chronic cough. However, studies yield inconsistent results, and this paucity of evidence is recognized even by the most current guidelines in this topic. In the context of the current knowledge gap, we aim to investigate the therapeutic effects of acid-suppressive drugs in patients with non-specific chronic cough. For this, we use the PICO framework, and we compared acid-suppressive medication to placebo in adults with non-specific chronic cough. Our main outcomes of interest were the impact on cough severity and quality of life, and we hypothesized there was a beneficial effect to acid-suppressive drugs in this context. We performed a systematic search on the 1st of November 2022 by using this search key, which is comprised of three main domains: the first one pertaining to cough, the second one to acid suppressor, and the third one to randomization, as we only plan to include randomized controlled trials. In the end, we found 11 eligible articles, and allow me to present some of our most impactful results. This first figure shows the mean change in cough severity in patients with non-specific chronic cough receiving proton pump inhibitors compared to placebo. Our measure of effect is the standardized mean difference, as various scales and questionnaires were used to assess the outcome. Just as a quick tip for interpreting our results, we should know that a standardized mean difference with a value between 0.2 and 0.5 is considered a relatively small clinical effect, whereas its value between 0.5 and 0.8 signifies a moderate clinical benefit. A standardized mean difference over 0.8 is considered a large clinical effect. And here you can see that we found a standardized mean difference of 0.33, which is statistically significant here as the diamond does not touch the line of null effect, which is translated into a relatively small clinical benefit. This data was derived from 9 randomized controlled studies, which total around 350 patients, with a relatively low heterogeneity, estimated to be only 16%. We also performed a time dependency analysis, and this plot shows on the x-axis the duration of treatment in weeks, and on the y-axis we have the standardized mean difference, which represents the clinical improvement. And as you can see here, longer treatment durations are not associated with a more marked clinical improvement. The fact that we investigated the effect of PPIs on both cough severity and quality of life is one of the main strengths of our first project, and we also provided additional insights by doing subgroup analyses and time dependency analyses. However, there are a few limitations as well. Probably the most important one is the fact that the number of included patients is relatively low, and the fact that the measurement of outcomes was entirely subjective using varying scales and questionnaires, not all of which were previously validated. In conclusion, we could say that treatment with PPI seemed to result in some modest symptomatic improvement in terms of cough severity, and that this effect does not seem to be dependent on duration of administration. In clinical practice, that could mean a potential beneficial effect in selected patients, but no additional benefit from extending the treatment duration. In terms of implications for research, we suggest that more high-quality RCTs be conducted with appropriate sample sizes, and maybe the employment of objective cough measurement techniques as well. Here you can see the current status of our manuscript, which is currently under review. A few words about our second project as well, which aims to investigate the risk of intestinal dysbiosis in patients receiving proton pump inhibitor treatment, again a systematic review and meta-analysis. As we all know, proton pump inhibitors are among the most widely prescribed medication worldwide, with recent estimates from Spain saying that 1 in 10 people is actually a daily PPI user. However, an increased risk of Clostridioides difficile infection has been described in PPI users with an up to 2-fold higher odds compared to non-users. We should bear in mind, however, that these results are only supported by observational data and could be the result of residual confounders and other biases. Therefore, our aim was to investigate this risk, but only in the context of randomized controlled trials. For this, we used the PICO framework and we compared proton pump inhibitor treatment to non-users. Our main outcome of interest was the rates of Clostridioides difficile infection. However, we also looked at other enteric infection and small intestinal bacterial overgrowth. In this way, we plan to assess the safety profile of PPI treatment, and we hypothesized that they do not increase the risk of intestinal dysbiosis. We have performed a systematic search on the 2nd of March 2023 using a search key comprised of 2 main domains. The first one pertaining to proton pump inhibitors, and the second one to the concept of randomization. As previously mentioned, we're only looking at randomized controlled trials. In the end, we found 17 eligible articles. We managed to meta-analyze one important outcome in 2 different analyses, the risk of Clostridioides difficile infection in patients receiving proton pump inhibitors, compared on one hand to placebo, on the other hand to H2 blockers. This first figure shows the results that we got when comparing patients receiving proton pump inhibitor treatment to patients receiving placebo in terms of risk of developing Clostridioides difficile infection. Our measure of effect was the risk ratio. We're all very familiar with that. A risk ratio of 1 means there's no significant difference between the 2 study arms. A risk ratio lower than 1 means that the exposed group has a lower chance of developing the outcome, whereas a risk ratio over 1 means a higher risk in the exposed group. And here you can see there's no significant difference between the 2 study arms. This data was derived from 7 randomized controlled trials, totaling a very large number of patients, over 25,000. And we can see that there's a very low heterogeneity, which is estimated to be 0%. To sum up this first figure, we could say that there's probably no significant difference in terms of risk of developing Clostridioides difficile infection in patients receiving PPIs compared to placebo. And a similar conclusion has been reached when comparing treatment with PPIs to treatment with H2 blockers. You can see here that the number of included studies is a bit lower, only 4, but the number of included patients is still very high, over 26,000, with again a very low estimated heterogeneity. The main strength of our second project is the fact that it comprehensively assesses the safety profile of PPIs derived from randomized controlled trials only. Of course, it provides some additional insights by comparing PPIs to both placebo and to H2 blockers, and the very large number of included patients. However, there are a few limitations as well. Probably the most important one is the fact that none of the studies were designed with Clostridioides difficile infection rates as the main primary outcome, therefore they may be insufficiently powered, and there's some heterogeneity regarding follow-up times and treatment duration times. In conclusion, we could say that we found that PPIs do not seem to increase the risk of developing Clostridioides difficile infection in patients compared both to placebo and to H2 blockers, and that's very important for clinical practice because it gives us a more clearer picture of the safety profile of PPIs. And in terms of implications for research, we suggest, of course, more high-quality RCTs with appropriate sample sizes to be conducted, and we suggest that an additional look may be to the other enteric infection and to small intestinal bacterial overgrowth. Here you can see the current status of our second topic, which is basically in the manuscript writing phase. This slide summarizes the current status of our 2 projects. The first one is submitted and currently under peer review, and the second one is in the manuscript writing phase and is expected to be ready for submission somewhere around March this year. I would like to thank you for your attention and leave you with one of my favorite quotes, which says that a smooth sea never made a skilled sailor. Thank you.
Congratulations. Regarding your first project, do you think will it change or daily practice? Because now, if you have a patient with a chronic cough, the recommendation is 6 weeks, high level, high dose PPIs. But from your data comes that the length of the treatment doesn't matter. Does it mean that only 1 week is enough and it's not effective, then forget it?
Thank you for your question. Actually, the most recent guideline from the American College of Gastroenterology regarding acid-suppressive drugs and gastroesophageal reflux disease has a separate section dedicated to extraesophageal manifestations, one of them being chronic cough. And they suggest that treatment could be administered for up to 12 weeks. So given our data, I would say that if they don't respond in 6 to 8 weeks, I don't think there's any point in suggesting extending the treatment duration to 12 weeks, because there's probably a very low chance the patient will actually develop symptomatic improvement over that extended period of time. So I would say that probably 6 to 8 weeks is a good option.
So congratulations to your presentation. I very much love your second topic. So I would like to ask, could you give us some more information about the population of those 7 RCTs? Are those actually patients who are at risk of Clostridium difficile, like some patients with broad spectrum antibiotic treatment, or are they just healthy patients for some other indications of EPAs?
Thank you for your question. That's a very good question, and actually our population has everything in it. Most of the studies that we included actually had either patients receiving PPIs compared to placebo or to H2 blockers for either prophylaxis of bleeding if they were taking antiplatelets or anticoagulant drugs. These were mostly patients that were in an outpatient settings. They were not hospitalized, so they were not at a specific higher risk for Clostridioides difficile infection. But we also have patients who are critically ill in the ICUs receiving PPIs or compared to placebo or H2 blockers for stress ulcer prophylaxis, for example. So our population, our total population has both types of patients. We have performed the subgroup analysis, but I did not have the time to present all my results. And we actually subdivided them into hospitalized patients or outpatients because we consider that to be a potential risk factor for Clostridioides difficile being hospitalized. And there was no difference between the two subgroups. And you could see that the results show a very low heterogeneity, which is estimated to be 0%. Regardless of the studies that were included. So there was no outlier or no more higher risk in one of the studies compared to others. So
if I may, one more question. Is there some chance that in inclusion criteria and exclusion criteria, the studies can actually select the population that would be in a lower risk of C. diff infection?
Thank you for the question. I don't think the population inclusion and exclusion criteria had some very specific risks criteria in terms of excluding patients that were at higher or lower risk for C. diff. They had, however, most of them excluded patients that received previous acid suppressors before being included in the study. So I think that's a very good thing because we're only looking at the PPIs being administered now during the study, not beforehand. But in terms of excluding patients with C. diff, I don't think any of the studies looked at potential risk factors for C. diff to exclude the patients beforehand. So.